Not only is Dr. Migliori, let's face it, a pretty bigwig at UnitedHealth Group, he's also one of the most knowledgeable people in healthcare. And he's such a nice guy, too. As Executive Vice President for UnitedHealth Group, Dr. Migliori is responsible for ensuring clinical excellence and linking that excellence to practical clinical outcomes and robust business results for 3 business segments, including Optum Insight, Optum Health, and Optum Rx. Dr. Migliori also serves as Chief Healthcare Officer of UnitedHealth Group Alliances, which is a division of UnitedHealthcare, Medicare, and Retirement. Welcome.
Thank you very much. We're going to have a conversation for the next 30 minutes or so, and I'd love to get engaged in the same kind of dialogue that I heard this morning. You really deserve, the organizers really deserve a lot of credit. The conversation I heard in this room this morning was at one of the highest levels of intellect around healthcare that I've witnessed. It's not characteristic of meetings like this to have this level of penetration and depth into healthcare. A couple of comments that I heard that were very important, the things around prevention and so forth, and we'll talk about that. But the other thing is about behavior, and it's not very helpful when UnitedHealth Group serves you dessert. By way of background, I'm trained as a surgeon. I'm a transplant surgeon, so therefore I'm not trained as a public speaker. My voice may drop. Raise your hand if you can't hear me. After all, when I went to work, I wore a mask. My client was asleep. And I sure as hell hope I don't have that same impact on you. All right. I've been at UnitedHealth Group for now 16 years, and when you heard the role that I have, there's nothing in there about digital. There's nothing in there about mobile. Despite my appearance, I'm not a techie. My role in the company is to help shape the design of things that we do to transform the way in which healthcare is delivered in America. But the more and more we look at that equation, the more and more important you all become. Because in order for us to know who we need to serve and how we need to serve them, and better yet, how we need to reach them and how we become part of their lifestyle, really requires us to get to know you more closely and what you are doing. Because I think you're the last gap in healthcare. You're going to be the ones that help us take what we've done. We've learned over those 16 years I've been with the company a few things. Number one, in order to help people, you've got to know people very, very well. And the investment that we make now, some $2 billion a year in technology, has to first be able to do that analysis to find out who we're serving and what to do with them. And we're very proud of that because that's been a long history. The problem has been, is what you heard this morning, is the adoption. And unless we can become part of people's lifestyle and put information in the hands in a way that they can use them, in ways in which compels them to take action, we're lost. Oh, by the way, we can do the same thing with the physician. And in the physician's sense, what we need to be able to do is to become part of their workflow and not a distraction. So let me take you down a little path and show you our perspective on really trying to transform the American healthcare system, and in doing so, reflect upon you our dependence upon what you're up to. Let's first talk a little bit about the American healthcare system as our patient. We're all in a group practice together. This is our patient. The patient's afflicted by a variety of things on this problem that's sitting on the front of her chart. First one is she has more needs as she's getting older. And some of that has to do with the obesity epidemic, but in general, at every age group, we are seeing more in the way of chronic disease. The second thing is that the system that serves them is very talented, but not very consistent. There's major differences in the judgment that physicians apply based on where you live. There's a fourfold difference in the likelihood that you'll get a hip repair in America based on where you live rather than the stage of your disease. Your zip code has more to do with your plan of care than the stage of your disease many times. The second thing is the differences in capabilities. There's a fivefold difference in the likelihood you will survive pancreas cancer surgery based on whether or not, based on how many operations your physician has done in the past. And much of that information isn't known to you. In fact, there are many interested parties, including the surgeon who does the operation, in keeping that information from you unless they have great results. But it doesn't make a difference to you when you're lying down at an operating table if you don't have true data. The third thing is that healthcare is getting more expensive. And despite the fact of what's happening in the rest of our economy, there's always going to be a continued increase in the price of care, in the cost of care. Half of that has to do with such issues as the current things that we have in healthcare becoming more expensive, sometimes irrationally. But the other part is that many of the things that we're doing to solve problems are very new, and they're replacing old, less expensive capabilities. Many of them very effective, some of them not. The third thing is America is a very fragmented healthcare delivery environment. You all know that. More than half of America's physicians practice in groups of 5 or smaller. In this country, by tradition, the medical record is owned by the provider, whether it's the hospital or the physician. So if you're going to multiple specialists to take care of a malignancy, because you need to, the surgeon, the radiation therapist, the oncologist, etc., they all may have a very different view of you. And I guarantee you that if there are multiple records on you, none of them are synchronized with each other, unless you're in a group practice sharing a common record. That makes care less likely to be effective, that threatens its efficiency, and most of all, it threatens its safety. The final issue is the consumers are very different. They are more demanding. And it's actually a source for us to be pursuing a provocation of the healthcare system to perform at its highest level. Just to reiterate something you saw very early this morning, the impact of obesity in America is dramatic, and it's caused an increasing burden. There's been a doubling of obesity rates in America since 1990s for every age group. And what you're seeing here is a correlation between each of these potential life-threatening diseases and certainly disabling diseases as an association with body mass index. Whereas you progress from normal weight to overweight to obesity, you see increasing levels of this. So the epidemic we have in terms of obesity is driving a lot of demand that's reversible. But the real issue that underlies all of healthcare for all individuals, irrespective of what stage of disease that they have, is really this dependency. This is the center of the healthcare universe. It's the exam rooms, the emergency rooms, the urgent care centers. It's the bedrooms across America in which day-to-day decisions about healthcare are being waged. And it's the collaboration of these two individuals that needs to be served with better information to be able to make better decisions. Because the current circumstances is that healthcare decisions that drive the American healthcare system are subject to the availability of information about the patient and its completeness. Second is the physician's access to and willingness to use evidence-based medicine as quickly as it develops, and it's developing at a tremendous pace right now. And then finally, the ability to track behavior once the patient leaves the doctor's office. I suspect this patient may be at risk for not being compliant with their medications, given that he's probably not following dietary guidance as well. But let's really characterize some of the decisions that go on in America. In the upper left-hand side here, let me see if I can do this correctly. Yeah, right there. About when Elizabeth McGlynn looked at in the physician's exam room, what they found that only 55% of the time were they tied to evidence-based medicine. 45% of the time they weren't. In fact, 11% of decisions made actually were harmful to the patient. Second thing in the upper right here is that adherence with medical therapy is challenging as well. Patient making a decision 6 months out, 50% of the time, to stop taking the medications without telling the physician. Oh, that's okay, because when you think about it, nearly 1 in 5 people who leave that exam room with a prescription for an asymptomatic chronic condition never fill a prescription anyway. What does that mean? Well, it means that medication non-adherence can lead to a variety of things, including many of the admissions and readmissions that we see in America, costing us, conservatively here, $100 billion. In fact, you listen to David Cutler at Harvard, it's over $200 billion a year in avoidable expenditure just because of the chosen behavior. So, what have we been doing for 16 years? When we look at our approach to modifying this healthcare system and to modernize it, we've been focusing in 3 principal areas. The first of which is trying to get people as healthy as possible, no matter where they're starting from, whether they're healthy to begin with and trying to stay that way, or whether they have chronic disease and need to stay in a program to maximize their best possible health status. What does that do? It reduces demand on the system, allowing people to avoid the preventable. About 50% of premature death in this country, 50% of premature death in this country is driven by self-inflicted injury. In other words, lifestyle behaviors. The second thing you do is for those people who do need to use the system, you give them tools of transparency so that they use the best parts of the system when they need to, making the best choices. The third component, and the place where we're putting the most recent investments, is in the bottom one. It's actually working within the healthcare delivery system to help it operate at its full potential, so when those people do enter the system, they're met by people providing care at the top of their game. You have a role in all 3, and let's get into that. First one is actually building a decision support system. To do that, you need to be very specific about people. Get down to the level of, for each one of these individuals, down to the level of what diseases they have, the care that they've rendered, and how that care can be improved. We do it with a tool called eSync. What eSync does is to take for all 70 million people we have, allows us to gather 75 different types of data that may be available on each one, and then to sort that data based on the implications of what diseases they must have in order for that data to be generated. Seeing an insulin prescription, you know that you're dealing with a diabetic, etc. But the second thing we do is to gather everything we know about that individual by the diseases they have, and then run it through a rules engine with over 950 evidence-based and economic rules about healthcare to look at the care that they received by condition as individuals and compare it to the care they should have had, and then doing the comparison. What is missing in the care that they've received, to get to the question we heard earlier today about, well, how do you keep these high deductible plans, how do you keep people focused? You focus it with this. You look for the care that's missing, you look for the care that's excessive, and you look at care that requires an alert. All of those things for every individual, based on their individual diseases, the actions they need to take, are listed in a personalized action plan that we use through a variety of media, that's where you come in, to share it with the ecology around them, the patient themselves, the physician who's providing care, and if we're involved with a case manager or whatever, or anybody who calls in to one of our clinical lines, these people. So everybody's working off the same prioritized, personalized action plan for those individuals. What this tool does is tell us the behaviors that should be placed by each individual for each problem that they have. The issue comes about is getting these three to pay attention. That's where you come in. Now, for the highest level of acuity, for the top 4 to 5% of our population that's driving over 40% of our costs, we don't wait for them to come to us, we go out to them. Telephonically, sometimes in cars. But what we do is to provide what eSync's given us and look at the decisions they've made. Are they seeing the right doctor? Are they on the right medication? Are they on the right plan of care? This person isn't seeing a primary care physician. We need to get that lined up. It's worth about 250 points. In fact, we score all of these points, so it builds a priority of what behavior needs to change. And through 300,000 contacts a day, we operate in this fashion. But there are a whole bunch of people that we know we can't reach by putting out phones because of this. What this shows is the comparative savings that occur based on patient severity on the x-axis here, and the amount of dollars saved by getting them to take these actions. This is important, because what it says is it's not good enough just to have technology that's operating. For us to embed it, it's got to work. In fact, what this technology does, it does work. And when we reach out to people, this is the savings based on these phone calls, we see the sicker they are, the better they perform. However, at a certain point, return on investment is negative. It's too expensive to call people at low severity. For those people, this tool has showed us we have to get there a different way. And we get there this way. Number one is we start putting things into portals. And in these portals, what we're dealing with is an ability to share information in a way that's intuitive to the user. The conversations we heard this morning about usability and user acceptance, etc., is something that's very core to us. We really have to become a better part of people's lifestyle and a deeper part of a physician's workflow. But in order to get there, you see we still have a lot of work. The way in which we array the information is show them what they have. We show the individual user what they can do about it. And then in this layer, show them how much progress they're making, both clinically as well as economically, if they're one of our 40 employers and 2 million people who get incentivized, they get financial support for doing the right thing. In fact, just to get to the conversation we had this morning about prevention and these high deductible plans, UnitedHealth Group covers this for people that we insure, and certainly we encourage our self-insured employers that for preventive services, you don't have an out-of-pocket experience. Those are covered down to the first dollar coverage. In fact, it was so important in healthcare reform that, as you probably heard this week, we're going to continue doing it no matter what the Supreme Court says. It is that important. But going to a portal may be a struggle, because the usability of a portal itself can be challenging. So where do you go? You go to where the patients are, as consumers. As you heard Nick talk about this morning, the use of mobile devices. And what we're doing with mobile devices, and all of this stuff is already in play, is having the ability to take that same personalized action plan that I showed you in more enlarged form and direct it to the phone. It's giving them access to their portal, to the phone. It's helping to look at a variety of healthy behaviors and measuring them by connecting with activity monitors. It's an ability to provide people behavior modification towards that first goal, getting people as healthy as they can be by becoming a deeper part of lifestyle. As you look at this, there's still plenty of work. We encourage it. We want to know what you're up to, because this can be a big help. Again, shortening that gap from what we know about people to actually making it a part of people's decision-making processes. I'll give you a case in point. Somebody asked, what do we do for our own 90,000 employees? Actually, we're 115,000. We have 136,000 people in our own employee benefit plan. It's a great place to learn. What we did for them is to create, everybody's on a high deductible plan. And what we had done was to, and it's been that way since 2005, but what we had done was to ask people to get involved with biometry, to give us some biometrics, their blood pressure, their fasting blood sugar, their cholesterol, and the body mass index. And if any of the 4 of them are off target, to enroll in a program to get back on target. They didn't have to achieve the desired weight, but they had to enroll. In doing so, if they were to do that, we gave people $450 per adult for just merely signing up and getting engaged in this program. 75% of our employees took a level of engagement to start giving us data. 51% gave us all of the data. 25% of people scored all of their points because there was a graded reward system. What did it mean? First off, it gave us greater awareness of the disease burden of our people. We found that we had 7,007 diabetics in the company, and 443 of them didn't even know it. We also were able to get our hands around what was going on with obesity and the like, and people started taking action. First off, they had better care-seeking behaviors because they stopped acting as if the health benefit is an entitlement. They became responsible purchasers. We had actually a 6-fold increase in wellness programs, including 45% of people who signed up for weight loss lost on average 9 pounds. What did that do? It changed the metabolism of UnitedHealth Group. And what's evident there? We had fewer diabetic complications, in fact, 19.6% reduction. We had 12.3% reduction in cardiac costs. 10 fewer of us had a heart attack. Putting together technology, analytics, and engagement provides us that kind of capability. We also saw an increase in people, let me go back for a second. We saw an increase in people getting screened for cancer. Why? Well, because when the biometrics were wrong, they had to go somewhere to go get fixed. They had a blood pressure issue, cholesterol issue. When they went to the physician, they also decided to let's get that colonoscopy done, let's get the mammography, etc. We started finding very small cancers. We had a 15% increase overall in the likelihood that somebody would get screened. What it did for us economically was this. The program was started here. Last year, it was down to, we started at a 9% trend. We went down to 3.9. This was 2.3. For 2011, it is 0.5. Changing people's behavior. Now, there was a second thing that we also wanted people to do, was to make sure that when they do need to use the healthcare system, that they're using the best parts of it. So those same analytics can look at a physician's practice and start scaling on the basis of how good is their quality of care. And then if they're at high quality, how efficient are they in preserving resources? And what we do is we scale the whole community to start recognizing these things. For instance, you take orthopedic surgery. Doctors who are high quality and high efficiency have a 55% lower complication rate. As a result, their cost of care are about 19% less. Would you like to know who those surgeons are before you get your knee done? Well, people apparently do. Because that 44% of docs who are in that category get about 70% of our work. How do they get there? They get there through tools like this. This is a mobile device. It's called Health for Me. We had an earlier version of this kind of physician finding capability and something called Doc GPS. Both of them are available free for our subscribers. In fact, Doc GPS is available for anybody. And I welcome you to use it. The tool is wonderful because it not only helps us identify when you travel urgent care centers that are under contract in the network, but also the ability to find physicians graded by their quality, no matter where you are, using GPS localization or a zip code you may want to manually put in. But it also allows you to also get the contact information to do that. In fact, if you're a client, we'll make the appointment for you. It also has an ID card, an electronic ID card, so when you show up, you're not scrolling through your wallet looking for an ID card you probably don't carry with you anyway. You have your account balances, your benefit designs, it has your claim history. Soon it's going to have treatment cost estimator that you heard Amanda talk about this morning. All of those devices to make it easier for people to navigate the system so we can get that second pillar done, helping people with transparency tools to use the system to its utmost. The final piece is what we do for the healthcare system. I'm going to show you about one example of how we are working within the healthcare delivery system. This is a tool that is used by our nurses. We have nurse practitioners who actually treat patients. About 1 million of our subscribers have both Medicare and Medicaid eligibility. Some of them are our most vulnerable clients. They have issues with mobility, they have issues with nutrition. They live in homes and live independently. We can't be calling them up and expecting them to be doing things. We go to their homes. We conducted over 117,000 home visits this past year when this data was finalized. They go into the house and they use an electronic record system in order to be able to track. And this is a EHR, a regular electronic health record. It's got the demographics, it's got the history of present illnesses, it's got the problem list, it's got all the medications, the vital signs, examination stuff. It's got screens for depression that we put people through. It's got screens for pain management and allow us to categorize not only the medical needs of the patient, but the capability of the patient to live in an environment that can support their needs. It's not good enough to give a patient a prescription if they don't understand how to take the medication or don't have the coins in order to do it. And that's what their role is. Can they live independently, and what can we do to fulfill those gaps? Does it work? Yeah, it does work. What we find is for this population who is at high risk, that we can take out anywhere between 28 to 34% of readmissions. Why? Because we make sure that what the physician has asked for can be accomplished and then solve all of the problems about getting it accomplished. It's not good enough for them to be getting good care direction. You also have to be able to provide the support systems in order to close it. So as I finish up, let me just describe what we're doing in terms of going back to something that has been age-old in our approach, getting people healthy, and for those that need to use the system, giving them tools of transparency, and finally helping the system to perform at its highest possible level. We have the ability, and we've invested a long period of time to get the analytics to know who to talk to about what. The real frontier is that last mile now. And that last mile is the things that you guys work on. It's getting people to fully embrace personalized information for both the patient and the physician to make good decisions now that they can be fully informed, tied to the current evidence-based medicine and ability to be tracked. And with that, let me start taking some questions.
This is all really exciting news. How long is it going to take when we actually have gain share or cost saving share really become a major part of the program so that all of those of us in the room, if we bring great results to UnitedHealthcare, we get to share in some of the profits that come from that?
I think you're raising a heck of an issue, and I don't even know what part of the industry you're from, whether you are in health management or healthcare delivery.
Well, actually, I come at it from two directions. My name's Kirk Saunders. I'm here as the chairman of Medical Referral Source, and we actually have a software tool that helps hospitals and physicians manage how and where referrals go. But I'm also here as a 16-year member of the board of directors of the Federally Qualified Health Center. It's having great outcomes in our diabetes management program. 100% of all that care is paid for by our foundation because we don't get a penny for managing that process. We're improving patient health.
I heard you ask a question this morning. Those organizations, the federally qualified healthcare delivery systems, are a vital part of the American healthcare fabric. There's some, 1,160 of them?
Yeah.
And they are.
In fact, we have 77,000 patients. We're one of the largest ones in the country, and all of our patients are poor, working poor people that either can't get insurance or, the notch group type. So yeah, it's a critical provider and extremely efficient one.
And you're doing God's work. Just a side on federally qualified health centers, some notions spoke of this morning about some of the most transformative things. We've done experiments in Colorado and the like where we've brought in telemedicine, working with Cisco, working with a variety of digital providers to link together the Centura health system with some of those devices. There were some things learned in that experiment we want to go back, fix, rebuff, but really critical for having a primary care physician in a remote setting where mobility is challenging, to have ability to simultaneously consult with the specialists of their need and the patient's need simultaneously on behalf of the patient. I think those are wonderful things. In terms of reimbursement has to change. I had the privilege of testifying before the Senate Finance Committee about 3 weeks ago. And one of the biggest issues they are recognizing is that in order for healthcare to continue to transform, you can't put providers in particular at risk for falling on their own swords. The system we have now results from the way in which we've reimbursed, at least part of it, is what's got to change is that when physicians and hospitals do things to create efficiencies, that they're rewarded for it, not penalized. And our current means of doing reimbursement have caused some of that. Some experiments we've done, one of them has been around for 19 years in our transplant program. We pay it for an episode of care. In fact, the people who get the greatest rewards are those that have the ability to continuously improve and thrive into that setting. And it's very popular. Other things that we've done, of course, there was always the history of capitation. In the 90s, we saw that failed. It didn't fail because capitation was a bad idea, it was because it was poorly executed. Having analytics like this to help physicians identify who's at greatest risk will help to do it. But having the ability to transfer risk, I think, is going to be important. The final thing is ways in which we need to start recognizing that one of the fundamental flaws in American medicine is the absence of coordination of care activity. And by providing technology that can enhance that, you also have to recognize that somebody is putting the day-to-day work into delivering that. And that kind of activity, payment for coordination of care, is something we're doing in several of experiments, both with ACOs and group practices, et cetera, as well as with patient-centered medical homes and other environments under not-so-clever names in which physicians and their office staff or their colleagues are taking responsibility for coordinating the needs of individuals, particularly as they go through those rough transitions between being a hospitalized patient to being home at discharge. Yes?
You mentioned the ACOs, and United has done a lot, I think, of ACO partnerships. How do these consumer or patient tools change in the context of an accountable care organization, where maybe there's not so much breadth of choice as to which doctor to go? Do they take on a different twist?
Yeah, it's a great question. I know you didn't have a microphone, so let me repeat it. In the day and age of ACOs and our participation, do we see that the functionality of these tools will evolve? The answer is yes and no. There are certain core elements within a tool that, for even in an ACO environment, you still might want to know who is the best surgeon for putting in Harrington rods when you have a spinal issue. It may be that there's now two parties that are interested in looking at that data. not just the consumer themselves, but also the primary care physician. After all, they're taking on responsibility for that patient in terms of the quality of care, in terms of their expensive care, and in terms of the health of that individual, the triple aim. These kinds of tools can help both patient and physician in their purpose in that fashion to be able to do it in that way. Will it evolve over time? Yes, because I think in more fully integrated settings, these tools can be even more important. One adaptation is to take it just from the ambulatory environment and bring it into the acute care setting. One of the capabilities we had, you heard Nick talk about Optum this morning, it's a third of our business. What Optum is a company that goes in and fixes the healthcare system. It is pervasive enough that it is actually helping now decision support tools in the emergency rooms, in the operating rooms, in the ICUs across America. 1 out of 5 emergency room visits has an Optum tool helping to either convey information or to make a decision. But you can see all of these tools are relevant because it's information. If I wanted to get down to a basic strategy, healthcare will improve when we can make it better connected, better informed to make more intelligent decisions, and then better aligned to get to the point about reimbursement that rewards and re-incents people to be doing the right thing. Physicians in the way in which we contract, and facilities in the way in which we contract, consumers in the ways in which we design benefits. Thank you for your question.
Hi, John Zifferblatt from Johnson & Johnson Healthcare Innovation. Richard, thanks for the talk. We always really remain very impressed with UnitedHealth and the innovation group there. My question's around customization of the content and the message to the consumer or the patient in terms of when you reach out and have a call to action for example, those patients who are popping up on the heat map that don't necessarily merit a direct phone call, but something like a help portal or Optimize Me. To what extent is that message customized and tuned particularly to who it's going to?
That's a fabulous question. The issue of customization, the importance of customization isn't just for the consumer, for their experience, it's also for their health. We continue to see broad disparities in quality of care across America. And while the information is indifferent to age, race, ethnicity, or gender, certainly the way in which we relate to people is. And so we constantly look at ways in which we do it. What we rely on mostly now is to do a shotgun approach for those that we don't reach out to by phone, which is to put it in a variety of different media. We can make it, the language appropriate, etc. But also, there's also ways of conveying things that are different from culture to culture. We have a lot to learn about that. But let me give you a case in point, some of the investments that are made. New Mexico, the demographics are high Hispanic, high Native American. The per capita income is relatively low. And as a result, you have a population with high levels of diabetes and a very low ability to get access to what they need. We put teletechnology in a truck and run a van out there and be able to connect the van with specialists on the receiving end, nurse practitioners on the other end that go through education, go through examination, and do what you need to do by bringing healthcare to people. But it's going to be those kinds of packaging of information and putting it in a way which is culturally and language relevant to individuals and do it. Give you a case in point. I have the privilege of working with AARP, as you heard in the introduction. One of the things that we've done jointly with ASI is that because of the sophistication that AARP has with relating to people, we've learned a lot. We've just published a paper this morning on the impact of cardiac disease in women, and coronary artery disease in women, and recognize that women are half as likely to get health care once they had the diagnosis, and yet it is just as prevalent. And So we've been working with the AARP to develop engagement processes. Dr. Ye is a very important part of that. Ways in which we can relate to a population to get women to take action. One of the things we've done and AARP helped us was to conduct the focus sessions that showed that the reason why women don't go is because they don't believe that women get heart disease, or they believe that the needs of their family come first, or that they don't understand their symptoms. By knowing those three things, we've been able to tailor messages to get people engaged. The other thing is to get them engaged is not to talk about trying to make them better, but to help them live independently as a result of maintaining their health. And we saw a 26% increase in engagement rates by doing that and relating to what their needs are. Thank you for your question.
Thomas Lee, I work for Roche. In the field of digital health, we heard about wellness, we heard about chronic diseases. My question is on the oncology patients. As we are working for survival of oncology patients, there will be more and more patients out there. So I'm interested to hear your UnitedHealth perspective in terms of priorities. So we pay attention to the wellness versus the oncology patients. Where are the unmet needs, and what is UnitedHealth's current thinking?
Thank you for your question. Let's talk about oncology for a minute. The cost of oncology are expanding faster than other portions of healthcare. Why? Because we can do more for people now. All right? The cost of care for a breast cancer patient in our own population has gone up 15% year over year. Why? Well, because some of the agents that were less effective have been replaced by biological agents, which are more effective. We also know that those agents have applicability for individuals earlier in the course of the disease and later in the course of the disease when other agents fail. So more people are being able to be treated by this thing. The issue that comes about is that many of these agents only work for a subset of the population with breast cancer. So we've come to learn a lot about heterogeneity of the people we serve. Now, you look like a younger man than I am, but when I was making decisions about breast cancer and treating patients, there were just a handful of things I had to keep in register to make what was then the best possible decision. When you look at the precision and the sophistication of treatments available now, and that's not that long ago, don't really take anything from that. When you look at the number of decision points that go into making healthcare now, there's no human brain that can put it all together. That's where digital medicine comes in, helping to identify those groups that are going to be helped and make predictions right off the bat. And so using things like genetic markers and proteomics and a variety of other things are those kinds of things that have to go into the mix. That's why your decision support tools can no longer just be dependent upon claims. But that's what I see as the role in oncology, bringing in some of these laser-guided missiles against cancer, but make sure you're targeting effectively.
Hi, I'm Greg Antone with Legacy Health Strategies. Those are interesting numbers on your employee program. I get the 75% enrollment, they got the check, and I was wondering if there's any more to that story, but the 51% participation is very impressive. Just wanted you to talk more about how that was done.
So the first thing that's done is that you recognize that healthcare expenditures on a year-to-year basis were growing, both in the size of the deductible as well as the cost of the premium out of their paycheck. You had to do something to get people engaged in helping to fix the problem. So we made a very simple decision managerially. Let's fully support those that are in this with us and start shifting more of the benefit in that direction. Very interestingly, by the way, year over year with this thing, we have increased the size of the subsidy towards the plan. First year was 450. This past year, it's been 600. It'll go up again next year. Sorry, guys. My crew's here. But as you do that, one of the things you start recognizing is the gap in care that occurs for everybody goes away with you because you've been taking direct action. We have other employers that instead of giving premium subsidy are actually putting money into health risk, HRAs and HSA accounts, and tax advantage accounts, to get people to fill in that gap. So what we see those gaps as doing is being places at which you shift part of the benefit in a way that's on a contingency type basis. If you do the activity, if you get engaged, you get there. The enrollment has stayed strong. The clinical trends we've seen in cardiac disease and other forms of metabolic disease continue to stay low. We won't continue to see a 19% decrease, but we certainly have blunted what diabetes has done to our population, given that 40% of our people walk around with an abnormal blood sugar.
Hi, I'm Laura Lindsay, and I am an investment banker in health information and media. A lot of companies are out here in the audience and hope to be able to partner eventually with companies such as Optum. My question to you is, how do you think about the buy or build decision when you're looking at new technologies? And when you think about that, when you decide to buy, how do you think about the value application between the technology that you're acquiring and United Optum's platform?
So a couple of things. It's UnitedHealth Group that I'm talking about. So it's both Optum as well as UnitedHealthcare that each make decisions, and at a global level, Nick Martin comes out of our shared resource for doing a lot of the innovation. So it's across the system. The decisions that we make are deliberate. We are not an organization that feels that we have to make it ourselves. We grew out of that a long time ago. Some of the best minds in this business are probably in this room here, but certainly they exist in this industry. And just as you see some of the best innovation, what we're dealing with is an ability to start harnessing and bringing forward that. When we start looking at it, we will weigh the value of the investment based on, the three things that it does. Number one, is this a tool that's going to help us grow because it makes the healthcare product better? Is it something that's going to enhance cash flow? Is it something, more importantly, that's going to build our reputation? By having it, will people recognize that the assets that stand behind it are some of the richest assets in terms of healthcare delivery, in terms of the information that we have, the talent that's brought it, the people the compassion that they have for using it, and the impact it will have on your health and well-being. So with that, I want to thank everybody for this time, and please enjoy your dessert.